Good evening, my dear colleague. First, I'd like to apologize for being a little late for about 5 minutes. Obviously, you can understand that there are some technical glitches that we have to iron out. This webinar is being co-hosted by Sri Lanka Dental Association along with the Commonwealth Dental Association. So due to that factor, we are reaching out to our colleagues over there in Canada as well as in the African continent and Indian subcontinent and all the way to Fiji. I'd like to warmly welcome everybody to our Friday seminar, or rather webinar on one of the restorative dentistry's very eagerly awaited topics. So let me introduce my dear colleague, Dr. Sonali Ranatunga. Dr. Sonali obtained the BDS from University of Peradeniya with second class honors in 2004. And then she proceeded to obtain her Doctor of Medicine in Restorative Dentistry in 2012 from the University of Colombo. And on the way, she gained a board certification as a consultant in restorative dentistry in 2013. And she obtained the membership in Endodontics Royal College of Surgeons of Edinburgh in 2016. And she's presently working as a consultant in restorative dentistry attached to the Ministry of Health in Sri Lanka. And I'd like to invite Dr. Sonali to give her presentation. Thank you.
Thank you, Dr. Sirimaman, for your kind introduction. So we'll move on to my presentation. After that introduction, I'm going to start my presentation today on behalf of the Sri Lanka Dental Association and Commonwealth Commonwealth Dental Association. So my topic today is endodontics and coronal restoration. So when I was invited for delivering of this lecture or this to do a presentation on the clinical meeting of SLDA, monthly clinical meeting. So I was thinking of a topic because I know most of the general practitioners are there to listen to this clinical presentation. So I discussed with Dr. Sirimavan as well to find out a good topic. And finally, I came to a conclusion to do a presentation on endodontics and coronal restoration. So why I chose this topic is basically in clinical practice, I see that sometimes good teeth with good endodontics or good root canal treatment failed due to poor coronal restoration. Sometimes the coronal restoration, the crown or the composite seems to be perfect, but the endodontic treatment seems to be poor. So therefore, I thought of doing this presentation to update your knowledge about this topic. So before going into the actual presentation, I would like to give you a brief introduction about what is endodontics. Actually, I think most of you all know what is endodontics. It is defined as science and it is precautions precautions taken to maintain the health of the vital pulp or the treatment of a damaged or necrotic pulp to allow the tooth to remain functional in the dental arch. So basically endodontics is aimed at maintaining the vitality of the pulp, or if the pulp become injured or damaged, to maintain the tooth in a non-pathological condition in the dental arch. So what are the endodontic procedures? So as you all know, there are main two types, vital pulp therapy procedures such as pulp capping, it can be direct or indirect, and pulpotome procedures, as well as the second one is a non-vital pulp therapy, that is the root canal treatment. So what are the aims of the above treatments? Basically, again, as I mentioned earlier, vital pulp therapy procedures are aimed at preserving the vitality of the tooth and keep the tooth in a non-pathological condition in the dental arch. Whereas if the pulp is irreversibly damaged, where the vitality can't be further maintained, then the pulpectomy and the root canal treatment is done in order to maintain the tooth in a non-pathological condition, a functional state in the dental arch. So for the endodontic success or the success of the whole treatment depend on both quality of the pulp treatment as well as the coronal restoration. If you have done a vital pulp treatment, the treatment matters, the final, how you do the treatment matters, the final success of the tooth and the coronal restoration as well. So both of these two parameters are important to maintain the tooth in a non-pathological condition in the dental arch with a good endodontic success. So I'm just briefly describe some important aspects regarding coronal restorations after vital pulp therapy procedures. As you can see in this photograph, so I must tell you that all of these, most of these photographs, patients' photographs are my own patients, or else some photographs actually again from one of our trainee, one of our registrar in our unit. So I should thank to her as well for providing me the necessary photograph. So this patient has, you can see that this patient has a crown fracture and end up with a pulp exposure. So pulp therapy is indicated in a condition like that, especially in an immature tooth. So after the pulp therapy, coronal restoration is a proper coronal restoration is a must. And it shows in most recent surveys in USA, Europe, and in UK that most frequent reasons for failure are surgical trauma and bacterial microleakage after the vital pulp therapy. So as an example, if I mention that during a pulp therapy procedure, you have to use the aorta handpieces and various techniques, materials. So this surgical trauma as well as the poor coronal restoration after you place after the pulp therapy to seal the cavity margins. These are the most recent failure for the vital pulp therapy procedures. And also several surveys have shown that the selection of one restorative material in preference to another can make a critical difference between success and failure within a few years. So that is, we have seen in practice, sometimes the practitioners after pulp therapy, they postpone the coronal restoration. Sometimes they place GIC for a few months. So it is not recommended. As soon as you do the pulp therapy procedure, it is always better to place a good composite restoration over the exposed treated pulp tissue. So that is to prevent microleakage and to enhance or the healing of the treated pulp tissue. So there are some important facts to be considered when you decide on coronal restoration. So as I mentioned, the placement of a good coronal restoration as soon as possible after the pulp treatment is very important to gain the final success. So material selection, as I discussed earlier, it's very important to provide the restoration longevity and bacteriometric sealing with tooth structure. And proper marginal adaptation of the restoration is also very important. So sometimes, although you have done the composite restoration, the proper marginal adaptation, that is the composite adaptation to the remaining tooth tissue, if it is not in intimate contact, there can be bacterial microleakage. And Also, regular follow-up to detect any complications and any defects in your coronal restoration, also very important after vital pulp therapy procedures. So this is again a nice case of our registrar. This is a reattachment of a fractured tooth, 3 teeth. Actually, this upper right lateral incisor has been pulp exposed, and you can see this patient has brought all these 3 parts. So fractured segments. So after vital pulp therapy procedures, we can reattach these fracture segments on the same visit. So you can provide a good seal to the injured pulp tissue, as well as you can provide a better coronal restoration with good aesthetics, and also you can improve the psychological condition of the patient. So why I selected this case to show you is, I think we have to practice these techniques in our general practice. Sometimes I have seen a lot of instances that patient has bought the part or piece to the dental surgeon, but they have not taken it into consideration, and they have done some other treatment. So this is a very good technique, or a very good method of improving the marginal adaptation as well as the aesthetics of the patient in one visit. So this is again another one, pulp therapy and composite restoration. This patient also has undergone an injury of upper right central incisor, exposed pulp, vital pulp treatment, possibly pulpotomy has been done, and composite restoration has been done. So if you use the light QGIC, then on the same day you can do the composite restoration as well. So these 2 patients' photographs has indicated the importance of providing a good seal after pulp therapy procedures. So this is again another case that this is a leak in coronal restoration which has ended up with pulpal inflammation. So as I mentioned earlier, major causes of failure after vital pulp therapy is the surgical trauma during procedure and microleakage of coronal restoration. You can see in this small child presented few months after the trauma, and it has been treated very early. Urgent emergency treatment has been done, but it is an uncomplicated crown fracture. So somebody has done the composite restoration. On the radiograph, you can see that there is a gap between composite restoration and the tooth, as well as some early signs of periapical pathology development. So these kind of gaps in between tooth and the restoration can provide areas to bacteria to lodging and microleakage, and finally end up with pulpitis and irreversible damage of the pulp, and finally with the periapical periodontitis. Therefore, in order to minimize these complications, it is a must to place a good coronal restoration after your vital pulp treatment as soon as possible. So this is a patient after 1 year follow-up. It's a successful pulp capping and with good coronal restoration. You can see in the first radiograph that the upper right central incisor, it has a large open apex, and the tooth has undergone crown fracture. And this radiograph has taken 1 year back, 1 year later after the treatment, and the composite is intact, and you can see that root growth has about to complete, and the root growth has been continued, and the apical closure has become small. So this is the ultimate aim or ultimate objective of our vital pulp therapy. To gain this, it's very important, the vital pulp therapy as well as the coronal restoration. So when you next, when you do a patient like this, so consider all these factors which I have discussed in these early slides. So that is some important points regarding vital pulp therapy. My main presentation is basically, it's based on the coronal restoration for root canal treated tooth. But endodontic it is not meant only for root canal treatment. Endodontics part is root canal treatment. So vital pulp therapy procedure also play a huge role when we speak about endodontics. So, but most of the time, we aimed, or we would like to learn about the root canal treatment and coronal restoration. But I personally feel if you do a proper vital pulp therapy procedures, we can prevent most of these root canal treatments in the future. So I think this root canal treatment and coronal restoration is a major part, or major practice area in general practice. Therefore, this would be very beneficial for you. So what is the aim of the root canal treatment? That is, the main aim is removing microorganisms from the root canal system and provide a seal to prevent their re-entry. This seal should be coming from the apical area as well as coronal region. So if there is a periradicular or periapical pathology, we have to provide an environment that allows healing of this periradicular lesion. So finally, the tooth can remain as a functional unit within the dentition, but provided the coronal tooth structure is adequately restored. So successful endodontics, therefore, is influenced or determined by many factors. One factor is the root canal treatment. The other factor is the coronal restoration. But the prognosis can be influenced by many other factors, such as individual patients. As an example, some patients, they are very educated, well educated, and they have their own measures, and they are more educated, therefore they know what to do. And the operator skills are very important for the ultimate endodontic success, as well as the treatment methods, because there are various treatment techniques available for current endodontics. So what the treatment method you have used, the amount of disinfection you have done, and finally the time. So all these are very important prognostic factors when we consider the success of the endodontics. And as well as each case, I would like to say, each case is a unique case. So I would start with this photograph. This is one patient presented to us like this, with a pain of an endodontically treated tooth. On examination, we found that there is a split in the tooth. You can see that the two parts are separated. They are when we insert a probe in between two parts, two cusps, we can move. The cusps are deflate. So this is an endodontically treated tooth. So it seems to be a MOD, mesio-occlusal distal cavity, where that clinician has not taken into consideration in providing proper coronal restoration, end up with this as a split tooth. So you can see the tooth after extraction, two parts are separated and the remaining GP inside the root canal. So this is indication where this is an example to show you the importance of a good coronal restoration. Again, another tooth, you can see that there is an amalgam restoration in this tooth, and mesiolingual cusp has been fractured. So it seems to be an MOD, maybe, and this in this patient also, that after a few months after the endodontic treatment, this cusp has been broken. So these are the usual or clinical presentations we gain in our day-to-day practice. So if you practice in your clinical setting, so you will come across these type of patients. So now I'm going to give you a question. So please have a look on this, and we are going to conduct a poll actually. So this is a 23-year-old patient after root canal treatment of upper central incisors. So there are 6 answers given. I think you can see the answers, and you can respond to the poll by giving your answer. I will give you 30 seconds or 1 minute. I can't see. Yeah, I can't see. I think Dr. Sirimavan can.
Yeah, I can see the poll. You only have 5 seconds more. Please answer as quickly as possible.
No, it's going time. You can give another 20 seconds.
This is the second question, I think. Shall I move to the first question?
Shall we give another 10 seconds more?
This is first question, no? Yeah.
Yes.
Yes.
Okay, we are terminating the first question.
Shall we move on to the second question? Okay. This is the second question. This upper second molar tooth needs root canal treatment. What do you suggest as the coronal restoration? Again, there are 6 answers. You can give your answer. Do you need more time? Yeah, we'll stop. No, later. I will discuss. Okay, so I'm going to discuss the answers for these two questions at the latter part of my presentation. So let's move on to the presentation again. So what are the functions of a coronal restoration? So as you all know that we have to provide a good coronal restoration with regards to the remaining tooth structure. So what are the functions? That it should protect from the occlusal load, especially the molars and premolars. They are the teeth that bear the occlusal forces. And again, it should reduce the likelihood of fracture because we are doing this root canal treatment most of the time for a compromised tooth structure. So it can further fracture or further cause the loss of tooth tissue in the future. And it should give a proper seal to prevent bacterial ingress because most of the studies have shown that bacteria can reach the apex of the root canal treated tooth as short or a period of time as few days, and even in a faster rate, endotoxins can reach to the apex of the root canal treated tooth. And the provided coronal restoration should be properly integrate with the remaining occlusion, and it should be cosmetically acceptable to the patient. So what is a good coronal seal? So good coronal seal is very important throughout the treatment and after the completion of the treatment. Usually the restoration of a root canal treated tooth begins before the root fill-in with an interim restoration, and during root canal treatment with a temporary restoration, and after the root canal treatment with a definitive restoration. So I think most of us are more concerned about the definitive restoration, what we are going to place as the final thing. But I see sometimes that we are not bothered that much of the interim restoration as well as the temporal restorations. Let's see why these are very important to us. So how do you start the root canal treatment? That the best way of starting the root canal treatment is with the removal of existing restorations and caries. So why we have to do is to assess the restorability of the tooth and predict the prognosis of the treating tooth, as well as for the diagnosis and for the treatment planning. If the restorability is questionable, we can apply some adjunctive measures to improve the restorability of such a tooth. And finally, we have to plan the definitive coronal restoration before we start the root canal treatment. And we have to educate the patient regarding the future definitive coronal restoration. Because most of the time, I think most of the practitioners don't think that much about the definitive coronal restoration at the beginning. And once you complete your obturation only, you sometimes tell your patient that we have to do a crown or whatever the thing. So I think it's better always if you can tell what is the end result before you start your root canal treatment. But sometimes these things can be changed with the treatment. Sometimes we have seen a lot of patients that in between treatment, they come with fractured teeth. So your treatment can be changed. Your treatment plan or protocol can be changed at any time, but it is always better to plan at the beginning. So evidence-based dentistry is very important in decision-making using available evidence, clinical judgment, and the patient choice. Especially at the beginning, if you can assess the restorability, so this unrestorable tooth, without wasting the resources, it is very unwise to waste the resources, and you can, at the beginning, you can decide on extraction and replacement of the tooth rather than try to make in an unrestorable tooth to keep it in a compromised state. And furthermore, it is very advantageous if you can finish the treatment as soon as possible, after deciding to do the root canal treatment, as soon as possible, if you can finish the treatment, then the prognosis will become more. Because the longer the tooth is left infected and more resistant the microbial colonies, as well as we have seen in clinical cases that prolongation of your treatment time can cause further fracturing of the tooth. So therefore, in order to prevent all these complications, it is always better to tell the truth at the beginning and take a proper decision at the beginning. And if you have decided to finish, do the root canal treatment, complete it as soon as possible. So for that, for the clinical assessment, you have to remove the all restorations. That means there is a need of replacement restoration during and following endodontic treatment. So, but in the literature, there is no ideal material which provides an ideal seal. So we always try to use the available materials in a good technique manner to give a best seal to the treated tooth. So what is an interim restoration? So this restoration is provided following dismantling and assessment of the tooth restorability. So you removed all the caries and all restorations, and you have assessed the restorability, and you have decided to go ahead with the root canal treatment, and you are going to place a new restoration as an interim restoration. Why is it important? It is important to provide a structural integrity, and which helps in rubber dam placement, and it provides support for weakened cusp, which prevent the fracture between appointments, and also it prevents the bacteria entering into the tooth as a good coronal seal. So what are the types of interim restorations? So copper rings or orthodontic bands, which reduce the cusp flexure, and you can build up entire tooth with glass ionomer cement and composite materials or as amalgam. So in this radiograph, you can see that this is one of my patients actually. My interim restoration is a leaky restoration. These things can happen to us as well. So you can see that there is a gap between the interim restoration and the tooth. So I noticed it just after the post-op duration, so we could correct it. So this is very important to have a good interim restoration while you performing the root canal treatment. So these are two photographs given by Dr. Samudi. So this is build-up of a tooth with composite. The first photograph, you can see it's after removal of all restorations and building up a tooth will give a better structural integrity, and rubber dam placement is easy. The second photograph is with an orthodontic band where you suspect, especially with cracked cusp or cracked tooth, you can provide an orthodontic band around the tooth which stabilize the tooth, and you can complete your endodontic treatment. So in anterior region, if you have decided a definitive restoration as the crown, you can provide a temporary crown which may act as an interim restoration. But you can see in this patient, badly paced temporary crowns, there is no marginal integrity and marginal contours are not good. So these are very important when you provide in a temporary restoration as an interim restoration during endodontic treatment, because marginal integrity is for the proper seal, and marginal contour is very essential for the maintenance of the periodontal tissue health. So when you do the temporary crowns as interim coronary restorations, so you have to consider these factors as well. So the next one is the temporal restoration. So what is the temporal restoration? It occupies the access cavity. So you build up the tooth and then you take the access, and then access cavity should be filled with the temporary restoration until the next visit. So if the endodontics is multi-visit procedure, this is very important because it provides a good coronal seal between appointments, and it should be easily removed, and there shouldn't be any additional tooth structure removed at the subsequent re-entry appointment. There are some materials which are regarded as good temporary restorative materials. One is CAVIT, which is composed of zinc oxide and calcium sulfate based materials, and IRM, that is zinc oxide based reinforced intermediate restorative material. And according to the literature and according to our clinical judgment, the temporary restorative materials always, most of the time, display the greatest coronal microleakage. In the literature, it is always recommended the GIC as a good temporary restorative material in between visits, and it says it gives a good seal up to 8 weeks. So it is very, very important as a temporary restorative material. So there are some concepts regarding this temporary restorative material as double seal. So that is, you can use 2 types of materials as temporary fill-in material. That is either CAVIT with IRM, like that way you can use. So before you place a temporary fill-in, you are placing a cotton wool underneath the temporary material. So this cotton wool will act as a cushion for the temporary fill-in, and it will be displaced. And if the cotton wool is exposed to the mouth, the saliva and the bacteria can go into the pulp chamber and down to the canal, to the apical tissues. So therefore, in the literature, it is mentioned that rather than placing a cotton roll or cotton wool, small piece of cotton wool, they have recommended some alternatives, such as sterile, well-adapted piece of polytetrafluoroethylene, that is PTFE tape, and sponges like Royco Endofrost pellets. So these are some recommended materials to be used as alternatives for cotton wool. So let's move on to the definitive restoration. So the definitive restoration should be placed as soon as possible after the completion of the root canal treatment. So there are a lot of research done in the world regarding this restoration delay and the definitive restorative delay and the failures of endodontics. So this person, Shugel, has found in 2007 that 40% of teeth with temporary restoration failed when compared with 21% failures of those with definitive restoration, because this temporary restoration, if you place it for a prolonged time period, it can cause a significant amount of micro leakage, causing ingress of bacteria into the root canal treated tooth, and finally failure. So it is mentioned that temporary restoration covering obturated canals should be kept for less than 2 weeks. So don't delay your definitive restoration after your good endodontic treatment. So I have seen that some practitioners think that we have to delay this coronal restoration, definitive restoration placement for a certain time period. It is not like that. If you have done a good endodontic treatment, then you can place your definitive restoration as soon as possible without any delay. So most of these studies has hypothesized that minimum time period between completion of root canal treatment and placement of the final coronal restoration is mandatory to gain the ultimate endodontic success. So what are the types of coronal restorations, you know? So the composite restoration, like your composite, and cuspal coverage onlays, maybe composite, maybe metal alloys, and veneers, composite or ceramic veneers, post and core retained crowns, metal crowns, PFM crowns, ceramic crowns without post. So these are some of the coronal restorations you can perform on a root canal treated tooth. So what is your opinion regarding GIC? Is GIC a good definitive restorative material? Actually, no. So GIC is not regarded as a posterior restorative material. So if you place GIC, so it should be strengthened, reinforced with composite. So a good practice, as I mentioned earlier, decide the coronal restoration when you decide to do the root canal treatment. So when planning the treatment for the restoration of root canal treated teeth, the following must be considered. What are these parameters or the factors? I will discuss one by one. The amount of remaining tooth structure, the anatomical position of the tooth, the functional load of the tooth, and the aesthetic requirements of the tooth. So we'll see what is the amount of tooth structure, remaining tooth structure. So a tooth may have undergone root canal treatment as a result of a crown fracture. So if there is a crown fracture, a part of the crown is missing. Maybe half of the crown, maybe less than half, maybe more than half. Or else, as a result of previous extensive restorative procedures or repeated restorative failures. It's a very common occurrence in our practice. We see sometimes repeated restorative failures. And sometimes it can be due to untreated extensive caries, maybe due to negligence or maybe due to any other reason. So all these instances, the tooth tissue or the tooth is weakened and it has a compromised tooth structure. Whereas in luxation injury, where the tooth has become non-vital, there is a minimum loss of tooth structure due to excess cavity preparation. Therefore, most of these instances, root canal treated tooth has a very compromised tooth structure. There are a lot of studies regarding this root canal treatment and the tooth structure has been done in the world. A study carried out in vitro has shown that root canal treatment reduced the cuspal stiffness by only 5%. Whereas a cut in a mesio-occlusal distal cavity reduces stiffness by 63%, suggesting that root canal treatment does not weaken the tooth per se, does not weaken the tooth. There is a direct relationship between the amount of remaining tooth structure and the ability of the tooth to resist occlusal forces. That is, if the remaining tooth tissue decreases, the amount decreases, there is a high possibility of the fracture. And most of the time, these, as I mentioned earlier, these root canal treated teeth are often heavily restored. Sometimes repeated restorations has made the cavity bigger, and it can be further weakened by the excess cavity preparation because the pulpal roof is removed during excess cavity preparation, which causes greater flexing of the tooth under function. So all these factors contribute to the more prone to get the root canal treated teeth for the fractures. So this is, these two photographs shows you the ideal excess cavity preparations on a premolar and upper molar tooth. So we can see that this minimal loss of tissues, if you can prepare an ideal excess cavity, there is a minimal loss of tissue. But is this the way we usually see in our patients? It is very rare to get a patient with very minimum tooth tissue loss. So most of the time, greater amount of tissue loss is seen in root canal treated tooth. So if you have a patient like this with minimum loss of tooth tissue, you can do a simple composite restoration as the coronal restoration. So as in this tooth, you can see that there is significant tooth tissue is remaining. So very important fact before you place the composite restoration is you have to clean the excess cavity properly, because the resin adhesive, everything depends on the cleanliness of your cavity. So we have seen sometimes the GP is not removed properly. When they come with dislodge restorations, we see that GP is protruding through the excess cavity. So that is, the pulp chamber is not cleared of the excess GP. So you have to remove the GP and make the excess cavity clean before you place the composite restoration, which causes a proper bonding to the tooth. So this is again another patient. You can see in this patient, this radiograph, there is a very large access cavity in the occlusal surface, and remaining enamel and dentin thickness seems to be minimum. So these are the situations we face in our day-to-day practice. Again, another tooth wear patient treated recently. So you can see in this patient, this molar tooth was treated due to tooth wear, and very less amount of tooth tissue is remaining. So this tooth as a this tooth is treated as a part of full mouth rehabilitation. So maybe this tooth is needed extra coronal restoration in full mouth rehabilitation. So these are the situations, amount of tooth tissue most of the time we get in our day-to-day clinical practice when we do endodontics. Then the second factor is the anatomical position of the tooth. So usually the anterior teeth are inclined at an angle to the occlusal plane. So the occlusal forces are not directed along their long axis. Therefore, if the anterior tooth is intact, in good tissue, and if there is only a minimum access cavity preparation, there is a minimum risk of fracture, and we can conservatively restore these type of teeth with composite resin. So whereas in posterior teeth, it carries a greater occlusal load, it needs a protection against possible fracture. Therefore, minimal occlusal access preparations in intact teeth, even in molars, if you can use composite conservatively to restore, and it has shown that improve the stiffness. The teeth with existing restorations involving the marginal ridges, maybe MOD cavities, require cuspal coverage restorations, either onlays or full coverage crowns. The third factor is the functional load of the tooth. The functional load is very important to design the final restoration, especially the tooth wear. The tooth wear, if this tooth shows the signs of tooth wear in that particular tooth, or the opposing tooth has the wear facet present, you have to be very cautious about the providing coronal restoration. There is a possibility of bruxism of this patient and end up with the failure or the fracture of the tooth. Especially bruxism patients have heavy occlusal loading, especially in the lateral direction. Therefore, it requires a stronger foundation. And if this tooth, if your root canal treated tooth is going to be an abutment for a fixed prosthesis or a removable prosthesis, it usually undergoes greater horizontal and torquing forces. Therefore, when you consider the root canal treated teeth as an abutment for the future prosthesis, you have to be very careful about selecting abutments, because especially those require long span bridge can end up with failure due to lack of retention and root fracture. Therefore, usually these type of patients are not suitable to provide long span bridges. Then the fourth factor you have to consider when deciding the final coronal restoration is the aesthetic evaluation. So usually in anterior teeth, due to trauma, the teeth become non-vital, and there can be bleeding from the ruptured blood vessels, and the pulp and necrosis can cause the discoloration of the tooth. Therefore, during endodontic treatment, if you are performing the endodontic treatment, you can remove all pulpal remnants from the pulp horn areas, and you can use a lot of irrigation with sodium hypochlorite during root canal treatment, as well as you have to remove the excess GP from the pulp chamber, and you can seal the GP at the cervical margin with GIC in order to prevent the discoloration. If the discoloration is severe, you can do non-vital bleaching. So this is my third question. We have a poll again. This is a root canal treated upper left central incisor. So what is your treatment plan? There are 5 options given. You can respond with your answer. We'll allow some time for this. Is the sub time okay? Fine. So there are 20 more seconds. Yeah. So writing now, time is up. Yeah. Okay, let's move. Okay, this is there are 2 patients we have treated inside outs with the inside outside bleaching. In this patient 1, discolored upper left central incisor treated with inside outside bleaching with carbamide peroxide, and patient 2 upper right central incisor treated with inside outside bleaching with carbamide peroxide. You can see that there's a marked improvement of the shade. So actually these things we have to promote these minimal invasive techniques in our clinical practice rather than cutting good tooth tissue and providing a crown. Actually, we have to convince our patients and do the best for them and with the minimal intervention technique. So rather than, especially in young patients, these 2 are young patients, so retention of their own tooth tissue is much better than providing extra coronal restoration such as a crown. So in first patient, after doing the non-vital bleaching, the composite restoration can be done. So you have to keep that in mind. After doing this non-vital bleaching, you have to allow at least 2 weeks to do the coronal restoration with composite. So you can introduce these things into your practice rather than providing crowns for each and every case. So in clinical practice, there are different clinical presentations when we talk about this coronal restoration. Sometimes one clinician both do the endodontics and the coronal restoration. Then you can decide your coronal restoration. Sometimes patients present with dislodged or partly broken coronal restoration done by you. The same clinician may be sometimes back. Sometimes patient present with root canal treated fractured or dislodged restorations, but the root canal treatment has done by a different clinician. So these patients can be symptomatic, may be asymptomatic. So let's see how to deal with this different clinical presentation. So how do you start? So if this patient come after the root canal treatment of somebody else, maybe by yourself. So anyway, you have to do the clinical assessment and the radiological assessment before you go into the coronal restoration. So clinical assessment, same as when you try to do endodontics by your own, you have to do the restorability assessment. That is, the remaining tooth structure, you have to assess quantity and the quality. That is, you have to see whether there is sufficient supragingival, caries-free tooth structure, circumference around the tooth to ensure preparation of a ferrule. What is the ferrule? I think most of you all may know what is a ferrule. A ferrule effect is defined as a 30 360-degree metal collar of the crown surrounding the parallel walls of the dentine, extending coronal to the shoulder of the preparation. If I say it more precisely, that is parallel walls of dentine extending coronally from the crown margin provide a ferrule. So in your crown preparation, there should be a crown margin. So from that crown margin, there should be supragingival tooth tissue, some amount of supragingival tooth tissue extending from that margin. So usually it says it should be around 2 millimeter. So why this is important? This is important that will elevate the resistance form of the crown from the extension of the dentinal tooth structure. And which after being encircled by a crown, this dentine tooth structure encircled by a crown provides a protective effect by reducing the stresses within a tooth called the ferrule effect. So you have to see when you assess the restorability whether the ferrule is there. So there are 4 direct factors influencing the ferrule, that is ferrule height and ferrule width, number of walls and the ferrule location, and type of the tooth and the extent of the lateral loads. So ferrule height, most of the time the clinicians think the important thing is the height, the 2 millimeter height. It is not the main factor when we consider the ferrule. Ferrule width also very important, that is the amount of remaining tooth tissue width, that the dentine thickness of the dentine. It's very important because this thickness will provide the strength of the tooth. And the number of walls, sometimes this number of walls are less. One side the ferrule is not there, the dentine wall is not there, and the location and the type of the tooth, whether it's a anterior tooth, whether it's a premolar or molar, whether the tooth has to bear the lateral loads, all these things should be the influencing factors when you decide on the ferrule. And also, if you are going to use a post, the type of post and the type of core material also very important when you decide on the functionality of the ferrule. So let's think when you assess the restorability of a particular tooth, if there is insufficient coronal tooth tissue for a ferrule, what to do? So you have few options. You can either orthodontically extrude the tooth, you can do crown lengthening, or if it is hopeless, you can suggest the patient to extract the tooth and replace with the fixed or removable prosthesis. Nowadays, with now we are in the dental implant era, so it's widespread and its use is widespread, and it provides an additional fixed tooth replacement option. Therefore, there is a reduced drive to retain the structurally compromised tooth. But my personal opinion, and I think it's in the literature also, the retention of his or her own natural tooth is very important rather than extracting and providing a prosthetic tooth. So these techniques, the orthodontic extrusion, the crown lengthening, can be utilized to improve the restorability of a compromised tooth. So this is a patient who has undergone a trauma to upper left right central incisor with a crown root fracture. So we treated, as she's a young patient, we treated her with orthodontic extrusion with the use of a metal post inside the root canal. So after the orthodontic extrusion is adequate, crown lengthening surgery was done, and fiber post root canal treatment completion and fiber post co-build up, and later on a temporary crown was done until she matures to age of 18 years. So you can see these techniques are very important in your day-to-day clinical practice, especially if for growing children, as well as sometimes these crown lengthening surgeries are important for elderly people who are not that much interested on placing implants. So you can improve the prognosis of your root canal treated tooth with these adjunctive measures. So after this clinical assessment, a radiological assessment is a must. Although this root canal treatment has been done by yourself, it's a must to have a proper radiograph to assess the quality of the root canal treatment, because it's a prerequisite for a proper coronal restoration. So it says a root canal filling within 2 millimeters of the apical terminus of good radio density with the absence of any voids and absence of any apical pathology is a must to go ahead with the coronal restoration. If the endodontic treatment is suboptimal, definitely retreatment should be done before, especially before post and core placement. So this is a patient referred to us. This patient requested a new restoration for a dislodged restoration 2 weeks back. History revealed root canal treatment done 1 year back. So what you can see in this radiograph, you can see unsatisfactory root canal treatment. There is no coronal restoration. Both roots seems to be having periapical, developing periapical lesions. So what is your treatment option? So my option was to do re-root canal treatment before giving any type of coronal restoration, because the endodontics is the foundation for the success of your treatment. Therefore, this endodontics is not promising. Therefore, we have to do retreatment. So if you are not competent enough to do retreatment, it is always better to seek expert advice to provide retreatment. Again, another patient. This patient requested a new restoration for this upper left tooth. You can see this upper left tooth is aesthetically very not pleasing. So before decide on anything, the radiological assessment is very important. So what you can see in the radiograph, you can see that possibly there is a fracture, and there is a ongoing root resorption. You can see the blunting of the apex, and there's a periapical pathology. So, and clinically, I noticed that there's a mobility. So all these factors together make this tooth an unrestorable. So it is always better to go ahead with extraction and provide a replacement rather than trying to do re-root canal treatment and other things like a compromised tooth like this. Therefore, it's very important to combine your clinical findings with the radiological findings before arrive at a conclusion on a coronal restoration. Again, another patient, recently found patient. This patient, 42-year-old male, complained of foot packing between lower right 6 and lower right 7. So he revealed that root canal treatment has been done 1 year back. So I ordered the radiograph. You can see that there's a root fracture on the distal root. So it's separated. So if I just correct the restoration, sometimes I may not see this. So it's always better to, better to have a restoration, although sometimes you may have performed the root canal treatment, but it is always, if patient comes after a few months later, few years later, it is better to have a current radiograph to see the current status of the tooth. Okay, so now I'm going to give you the answers for the questions. So what is the poll result? I think these two teeth have been treated with root canal treatment, and we'll see what is the answer, most frequent answer given. Question number 1, that is bleaching and composite restoration. Yes, good. Okay, so you can see that 58% have given that answer, the fourth answer, actually that is the treatment of choice for this patient, but considerable amount has given the composite restoration. But actually these are discolored teeth, so they are not aesthetically pleasing. So we have to give much consideration on that also. Yeah. Then we'll go, yeah. So this is the post-op radio, the photograph of that patient, the endodontics and the non-vital bleaching, inside outside bleaching. I'm sorry, I don't have the photo with the composite restoration. Okay, the question number 2, the answer, most of them have given the post and core build-up. So we'll see. Actually, this in molars, the post placement are not that indicated. So being the second molar tooth, the aesthetic concerns are much less, and you can preserve most of the remaining tooth structure. So I would like to go ahead with the metal crown for this tooth rather than having a post and core build up alone. So post placement in a molar nowadays is not that recommended. So I will discuss it in further slide. Yeah. The question number 3, root canal treated upper left central incisor. What is your treatment plan? Yeah. Most are given the number 2, non-vital bleaching. Yes, that's the correct answer. So most of the time, these type of discolorations are common with long-term calcium hydroxide dressings. That is, if you leave the calcium hydroxide, in the access cavity for a long time, end up with a discoloration like this, as well as inadequate removal of GP, also a cause for this type of discoloration. Okay, this is, so most of you have given correct answer for the question number 3. So question number 4, this is just to have a discussion. A 28-year-old young male requests restoration of upper right 2 and upper left 1. What would you do? So you can see in this clinical picture, this upper right 2 is grossly broken down, upper left 1 also the same, and there is an unaesthetic composite restoration on upper right 1, and you can see he's partially dentate, and there are some stains, maybe beetle stains or smoking stain. So all these factors should be considered to provide proper coronal restorations to restore the aesthetics of this patient. So in a situation like this, with grossly broken down tooth tissue, you may have to use post and core for build-up of these teeth. So what is the importance of post and core? So this is a treatment modality used for structurally compromised teeth since 1728. That is, Pierre Fauchard described the use of metal screws in the roots of a maxillary anterior teeth to retain crowns made from ivory and bone. So over 200 years ago, there are documents that use of post made from wood, gold, or platinum. So nowadays, we are having a variety of post, and let's see what is the function of a post. So what is your answer? What is the function or functions of a post? Whether to improve the strength of the tooth, to provide the retention for the core, or to reinforce the restoration. So the answer for this question is to provide the retention for the core. So I think most of the clinicians think that by providing a post to a root canal treated tooth can strengthen the root or the tooth. Actually, it is not. So it is used to retain the core only, or to retain the crown, core and the crown both. There is no such reinforcement of the restoration of the tooth when you use a post. Therefore, a sound understanding of the biological and technical consideration in the provision of post and core restorations will allow the clinician to offer this treatment modality to appropriate patients with greater predictability and reduce failure. So sometimes we have seen that some post are placed unnecessarily on good tooth tissue. So posts are not to reinforce the teeth. If there is a compromised tooth with less tooth tissue, the post is used to retain the core or the crown. So in the literature also, there are so many articles describing, and the success, in this Sorensen and Martinov demonstrated that success with this treatment modality is possible. The success rate of 87% with tapered cast posts and 100% with parallel-sided posts respectively, when the length of the post was greater than the length of the crown. So this is somewhat an old publication in 1984. And some other person also reported that crown teeth with good quality endodontics treatment with the post and core with an optimal morphology has a 25-year survival rate in 1992. So anyway, most of these studies demonstrate that clinical success is significantly reliant on the operator's skill and the appropriate case and material selection. So what are the factors you have to consider when you select a post? In most cases, the post and core restorations are only considered for anterior teeth with insufficient coronal tissue to retain a crown independently. Most of the time now, the posts are not indicated for molars, as retention of the core can be usually obtained using the pulp chamber and the coronal 2 millimeters of the root canal system. I think you have heard of this Naya core, which is used with amalgam restorative material. So the same principle can be used with composite also. In some literature, they advocate that to use 2 millimeters from the coronal root canal to get the retention of the core. So premolars, they usually lack sufficient pulp chamber space. Therefore, most of the time they need a post. So why molar teeth? Let's see why molars, the recommendation for post are not that indicated. The post preparation in posterior teeth, it can result in lateral perforations due to curvature of the root. Therefore, you have to know intimate knowledge of root anatomy along with the appropriate radiographic assessment is a must for successful post and core restorations in posterior teeth. To assess this radiologically, you have to have parallax images, that because in one image, it will only show you the mesiodistal curvature only. To see in the other directions, you have to change the direction of your the beam, X-ray beam, and take in another direction. So, and the other thing, most of the studies have shown that post-retained crowns in heavily restored molars as an alternative to extraction are very successful with the large number of these restorations remaining intact for 4 years post-treatment, that is with poor prognosis teeth, molars, as an alternative to extraction. This has been done and they have been intact 4 years post-treatment. Therefore, the appropriate case selection and operative technique is very important for the success with the post. So when to place the post and how long do you have to wait? What are the considerations? So according to the European Society of Endodontology, they suggest you have to see a radiological assessment after your endodontic treatment to see complete healing after 1 year. So if there is no complete healing has occurred, you have to wait 4 years to see the success of your treatment. But can you wait 4 years to place the post? It is unacceptable time to wait before placing a definitive restoration, because there's a high chance of leak in your professional restorations. There is high chance of fracturing. Therefore, following obturation of the root canal, immediate preparation for post placement has a number of additional advantages. And after when you do the post preparation, you should it should be kept in mind that 4 to 5 millimeter of GP should be remain apically. I will discuss this. So you can see in this diagram, this is actually downloaded. diagram. So you can see that apical 5 millimeter should be kept for 5 millimeters, and this is the post space prepared, and this is the core build-up, and this part is the ferrule. You can see the ferrule 2 millimeters, that is from the future crown margin, the available dentin height, and this is the ferrule width, thickness. So it says the height of the crown and the length of the post at least should be equal, or it is always better if this the length of the post inside the root is, if it is higher than the crown height. So when you decide on post placement, you have to consider these factors. The longer the post inside your canal is much better, but you have to leave at least 4 to 5 millimeters, and your crown height, when you decide the length, it should exceed your crown height. So these are some of the factors you have to consider when you place in your post. So again, the longer the post, it's better, and short post not only have poor retention, but also transmit larger lateral forces to the remaining root structure compared to the longer post. When the post length is greater than the greater the resistance to vertical displacement, and the greater the distribution of stresses within the root canal system. So vertical displacement is less when the post length is great, and the distribution of stresses also very favorable. And adequate width is very important for the post strength and resistant to post fracture. And also it is suggested that a post should not exceed 1 millimeter in diameter at its tip, that the tip should not be exceeded 1 millimeter. So dentin thickness is directly related to the radicular fracture resistance, with teeth with greater thickness of dentin showing higher long-term success. So when you do the post space preparation, be careful not to remove the excess dentin from the root. And it says that if you use a threaded post, there's a high chance of root fracture. And periodontally compromised teeth are not candidates for post and core treatment. And it's not very clearly mentioned in the literature that sometimes in vitro studies has assessed the stress distribution in relation to the bone height, that they say that the stress concentration is high in dentin if post has been placed in a tooth where the alveolar bone levels are 4 millimeter below the cemento-enamel junction. That is, from the cemento-enamel junction, the alveolar bone start 4 millimeter below that junction. Then the stresses are more. So then this width if it is 2 millimeter from the CEJ. So it is not clear about that very much. But anyway, periodontally compromised teeth are not good candidates for post and core restorations. So post selection is another subject. So I can't discuss everything in this presentation, but I have given an overview of post, indirect post, direct post with the application. Indirect post can be base metal alloys and can be constructed with type 4 gold. And direct post can be based on the material. They can be metal post like stainless steel, aluminum, titanium. And it can be non-metal post such as fiber post, ceramic, and composite. And based on the shape, parallel-sided, tapered, and active and passive post. So this is the latter part of the presentation, and this patient requests a new crown for this tooth, upper right one. So what would you do? So you can see in the clinical photograph, it's a discolored crown, probably acrylic crown. In the radiograph, there is a post, unsatisfactory root canal treated tooth, and there is a periapical pathology. So the treatment was the re-root canal treatment, fiber post and core buildup, and a new metal ceramic crown was given. So that's why the radiographs are important before you proceed into the final restoration. So complications and nitrogenic problems of post placement. So this is a girl requested with a request of a new restoration for upper left one. You can see the direction of the post end up with a possible root fracture. In the radiograph, you can see that there's a radiolucency indicating a possible pathology developing there. So post placement can end up with perforations like this. And this is again an unusual presentation. This is patient treated when I was working at Coronary Hospital. So you can see that a metal something has been placed, maybe a metal wire or something, which like a hook, and there's no root canal treatment done. So before going into the proper treatment, this metal part was removed and root canal treatment was done. So this is again an unusual type of a presentation. And this is the last slide. So this 23-year-old girl referred by an orthodontist for opinion regarding lower left 6. You can see this. She requested the preservation of this tooth. There is no need of extraction in the lower arch. So what are the findings? You can see that post end up in the furcal region, unsatisfactory root canal treatment with 2 lesions on both roots. Post, after removal of the post, it was a very large post, you can see. So MTA repair of the perforation and re-root canal was done in order to improve the prognosis of the tooth. So I would like to conclude my presentation with this. The successful endodontic treatment need careful handling of tissues, material, and clinical skills to gain good apical seal and coronal seal. But this already complex, this is not a straightforward treatment, the root canal treatment. So it's a complex or complicated treatment, but it can become more complex with iatrogenic introductions to the already complex situations like this. Therefore, if your clinical expertise is not that much in managing these patients, it is always better to improve your knowledge and clinical skills. So this is the final slide. So I would like to conclude with these 2 quotes. The capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. So you have been gifted by the Sri Lanka Dental Association, providing you the platform to learn, and it's your choice to learn. And finally, after this learning session, change is the end result of all through learning. That is, if you can't change, because I know some practitioners, they have their undergraduate knowledge still, so it is always better to attend to this type of clinical meetings and update your knowledge and improve your skills and ultimately change your practice to get a better outcome to your patient. Thank you. So I would like to thank you, the SLDA, especially Dr. Siriman Samarakon, who invited me to deliver this presentation. And I hope you have gained some kind of a knowledge, at least, to improve your outcome of your future treatments. Thank you.
Thank you, Sonali, for a very informative and you can call it as comprehensive lecture or it covered all the aspects of post-endo restorative options. And I think we have some questions coming up as well. So we filtered it, and so basically you covered with some of the questions that you put on the screen. And there's one question which was not really covered, so I'd just like to ask from you. Now, considering the restorative options that you talked about regarding in Sri Lanka, how would you rate the financial affordability of the patients and recommending various treatment plans for the patient? How would you go about doing that?
Yeah, it's a problem. So in wherever you practice, so all this involves these coronal restorations, root canal treatment, involves cost. So even in the government sector, even in the private sector, it involves a cost. So sometimes it's very difficult to convince the patients. And I think we have to develop our own skills, especially in general practice, when you consider about this economical status, to develop some kind of a skill to deal with the patients. So it's difficult.
Yeah, because when you are practicing in a constrained environment, you have to take a lot of things into consideration before suggesting or rather coming up with a treatment plan. So that is the core message that Dr. Sonali gave us. So it's been not only a very informative one, it's been a very interactive one as well. I think because we had 3 questions where you have been given the chance to participate. So it made it very interesting, as well as it made you feel like that you are actually asking questions from the presenter, which I think is a sort of a novel way where we are sort of moving away from our traditional lecturing pattern. So I'd like to thank Dr. Sonali for that innovative approach as well. All in all, it's been a very comprehensive presentation. Thank you so much, Sonali, for coming on board and giving this valuable lecture, spending your valuable time in formatting and formulating these slides as well. And I have some announcements to be made. That is the next lecture, which is scheduled in 2 weeks' time. That is the end of the year as well. So given the constraints of this number of holidays falling on those days, we are having a little, you can call it as trouble of finding a suitable lecture. There are some who are, we reached out to, we are yet to get an affirmative answer. So if we do get an affirmative answer, we'll let you know regarding the next lecturer who will be coming on last Sunday of this month. But I do have an announcement for the lecturer who will be doing the second Friday presentation in 2021 January. This is Dr. Chanaka Disanayaka, another restorative consultant, and he'll be talking about developments and clinical overview of indirect restorations. I'm sure it is going to be another interesting one like the one that we had. So I'd like to wish everybody good night. And if we do not meet during the next 2 weeks, I'd like to wish everybody a happy 2021. We have to forget about this year, but we'll be looking forward to the next year. So the good thoughts or the good vibes should be there in the air so that we can all move on to a better year. Let's hope. So good night. Thank you for joining.